So this is the sensory system disorders part 2. And the first disorder we're going to talk about is cataracts. So cataracts, these result from clouding of the lens. It can be in one or both eyes. And cataracts may be congenital, acquired. They can be caused from a long-term use of corticosteroids, diabetes mellitus, hypertension, and smoking. So these symptoms are painless, but they include blurred vision, difficulty reading fine print, double vision, photosensitivity, glare, abnormal color perception, and difficulty driving at night. So blurred vision is often the first symptom. You want to observe the patient for difficulty in reading, note any sensitivity to light. And for the diagnostic test, so they're going to examine the eye using the ophthalmoscope or the slit lamp. And a totally opaque lens creates the appearance of a white pupil. So for medical management, surgery is the only definitive method of treatment. And so this type of surgery called phacoemulsification, it uses ultrasound to break up and remove the cataract through a small incision, thereby reducing the healing time and decreasing the chance of complications. So after this, the patient must wear protective eyewear at night and protected goggle-type sunglasses during the day. Your nursing intervention. So you want to tell the patient to avoid any activities that can increase the intraocular pressure. So no bending, stooping, coughing, or lifting. You want to use an eye shield over the operative eye at night, and you don't want to give any aspirin. So for the next disorder, we have diabetic retinopathy. This is characterized by capillary microaneurysms. So these are going to be your little blood hemorrhages, and they form new vessels and connective tissue. So this disorder, it occurs in patients with long-standing, poorly controlled diabetes mellitus. So as the disease progresses, the blood vessels in the retina begin to widen and become tortuous, so they start to turn. And these microaneurysms then develop at the periphery and small hemorrhages develop. The new blood vessels form on the retina and into the vitreous body. So the new blood vessels rupture, causing decreased vision. So this is just saying that they form these little hemorrhages, and when those rupture, it leaves this scar. So the scar is what's blocking their vision. Okay, so in the advanced stages, the patient has progressive vision loss and the presence of floaters, which are minute products of the hemorrhage. So for assessment, varying degrees of vision loss, you want to assess each patient's knowledge of therapy and treatments, and also they can do the slit lamp examination. So for medical management, you have photocoagulation, vitrectomy, and chirotherapy. So in photocoagulation, they use a laser beam to destroy new blood vessels, seal leaking vessels, and help prevent retinal edema. With the vitrectomy, this removes vitreous humor from the eyeball. And your chirotherapy, this is your freezing therapy. So the tip of a probe creates a frozen area that extends through the external tissue and reaches a specific point on the retina. Your next disorder, age-related macular degeneration. This is slow, progressive loss of central and near vision. The most common cause of vision loss in people older than 60. So this is happening just because of the normal age process. And there are two types, which you don't have to go into too much detail, but you have your wet and dry. The wet is a sudden new vessel growth in the macular region, and the dry is caused by degenerative changes, including lipid deposits. So the hallmark of ARMD is the appearance of drusen in the fundus. And the drusen are yellowish exudates from beneath the retinal pigment epithelium and represent localized or diffuse deposits of extracellular debris. The main symptom of macular degeneration is gradual and variable bilateral loss of central vision. So a gradual loss of ability to see objects clearly. This is part of the assessment. You want to assess any distorted vision, gradual loss of clear color vision, scotomas, which are blind spots in the visual field, or dark or empty area appearing in the center of vision. So for the diagnostic test, they're going to do what's called the Amsler grid. And medical management, there's usually no treatment. Use peripheral vision for seeing, and they may use photocoagulation. So not much that they can do about this one. So even though they've lost their central vision, they can still have their peripheral vision. Next is retinal detachment. So this is a separation of the retina from the choroid. As the detachment progresses, it interrupts the transmission of visual images from the retina to the optic nerve, and the result is a progressive loss of vision to complete blindness. Clinical manifestations, so a sudden or gradual development of flashes of light followed by floating spots. And as the detachment progresses, the patient may describe an enlarging dark spot in the visual field, and the patient describes this as having a curtain or shade being drawn over the eye. So in this picture here, this would be like them looking out. They would see those little floating spots, and then in the corner here, you can see this is what they mean by they have a shade or a curtain being drawn over the eye. So they're seeing this black fade when they're looking out. So for medical management, one of the things they can do is called the scleral buckling. This helps seal the retinal breaks and relieve inward traction on the retina, as you can see in this picture here. They have what's called the pneumatic retinopaxy. This is your gas tamponade. So this is injection of gas into the vitreous cavity to form a temporary bubble that closes retinal breaks and places pressure on the separated retinal layers. Your nursing interventions. So if air is injected into the vitreous, the head is positioned with the unaffected eye upward and the patient lying on the abdomen or sitting forward for 4 to 5 days. Dark glasses are prescribed after removal of eye patches to decrease the discomfort of photophobia, and they want to refrain from any strenuous activity. So your next major disorder is glaucoma. And with glaucoma, you have what's called open angle and closed angle. So your open angle, this represents about 90% of the glaucoma cases. So this is going to be your most common form. And this is the outflow of aqueous humor is decreased. So the drainage channels become occluded like a clogged kitchen sink, and they're going to have loss of peripheral vision. They're going to have eye pain, difficulty adjusting to darkness. They're going to see halos around lights, and the inability to detect colors. So with your closed angle, this is an abrupt angle change of the iris, causing rapid vision loss and dramatic symptoms. The patient's going to experience excruciating pain in or around the eye. The sclera is red, and the pupil is enlarged and fixed, and the patient sees colored halos. So in open angle glaucoma, this is the inability to detect colors, but with closed angle, they're seeing these colored halos. So just the difference between these two. This one is going to lose loss of peripheral vision. And over here, the pupil is enlarged and fixed. So just know the difference between those two. So for both types of glaucoma, the diagnostic test, they're going to do tonometry. It's used to determine the intraocular pressure, and the normal pressure should be between 10 to 22. So in this type of patient, you're going to see elevated ranges of your IOP. Medical management. So with open angle glaucoma, there's 3 types. There's beta blockers, your miotics, and your carbonic anhydrase inhibitors. Your beta blockers, they're going to reduce the IOP. So you have your Bethaxol, your Timolol. You have your miotics. They constrict the pupil and draw the iris away from the cornea, allowing aqueous humor to drain out of the canal of Slim. So this is your Pilocar. And then your carbonic anhydrase inhibitor. This decreases the production of aqueous humor, which results in a lower IOP. So you have your Diamox. And then with your closed angle, they're going to use osmotic diuretics such as mannitol. And they're still going to use the miotics and the carbonic anhydrase inhibitor. So the only difference between the two is with open angle, you're going to use a beta blocker. And with your closed angle, you're going to use osmotic diuretics. Nursing intervention. So you want to stress the importance of early detection and treatment and preventing long-term visual impairment. So they need an eye exam every 2 to 4 years if they're age 40 to 64, and every 1 to 2 years if they're 65 and older. Also, you want to let the patient know that eye drops may be taken for a lifelong, so they're going to have lifelong treatment of eye drops. And you want to avoid the use of mydriatic or cycloplegic drugs. And so you're not going to give any atropine or epinephrine. Okay, so going into corneal injuries. And so this is just some of the most important things. These aren't necessarily the disorders, but this is just information that you still need to know. So burns are medically treated. You can do 20 minutes or longer with normal saline flush immediately after burn exposure. This helps prevent scar formation and subsequent loss of vision. And both eyes should be covered while the patient is transported to the hospital. And this prevents it from involuntary moving with the other eye. Enucleation, this is surgical removal of the eyeball. Post-op, you want to apply a pressure dressing over the socket of the eye to control hemorrhage. You want to observe the dressing at least every hour for the first 24 hours. And you want to avoid routine procedures of coughing and turning onto the affected side to prevent sutures from dislodging or hemorrhaging. So normally post-op, you would tell a patient to cough, deep breathe, but if they just have their eye removed, you don't want to do anything that's going to increase pressure or put strain on the eye because the sutures may come apart. Vitrectomy, this is removal of excess vitreous fluid caused by hemorrhage and replacement with normal saline. So the patient is required to lay on their abdomen or sit forward, resting the non-operative side of the head on a table to allow air that is in the eyes to float against the retina. And this position is maintained for 4 to 5 days. So that's the end of part 2. In part 3, I'm going to talk about the disorders of the ear. So go ahead and click onto that video, and I'll see you over there.